Welcome to the webinar that's going to tell you about the E&M coding guideline changes for 2021. And we are having this webinar with my go-to man for all of these things, y'all. He's the one who helped me to get my CPCO, that is a Certified Professional Compliance Officer. He wiped my tears, reassured me that I would not fall flat on my face, that he educated me on all of the things that really confused me. I don't know what I would do without Dr. Mario. And more than that, y'all, his wife, I love her immensely. If you ever have the opportunity to hear this man speak live and in person, you should. He is funny, and oh my gosh, he's funny. He makes any class on any topic interesting, and his wife is always sitting in the front row, and she is a hoot and a half. So, if you have not heard of Dr. Mario yet, you are missing out. And I want to encourage you right now to Facebook, go to follow askmario.com because he posts everything before everybody else. I know because I follow everybody. Anytime something new is coming out, Dr. Mario is one of the first people to do it. Check out askmario.com. He is the man when it comes to coding, documentation, compliance. He knows it all. And just like you, he's also been in practice. He's not somebody who just teaches about how to do these things. He actually worked in practice every single day up until about 6 months ago when he retired, but only to focus most of his time in helping other practitioners just like yourself. So he knows what it's like to be in your shoes. So, ladies and gentlemen, without further ado, the Dr. Mario Fucinari.
Thank you so much, and thank you, Christy, here. So let's get those slides on now. And there it is. Okay, good. Thank you, everybody. And here we go. We're going to get started here. And if you don't know who I am, Christy, when I listen to Christy talk about me, I'm thinking, who is this guy? And it's like, me? But anyway, I thank you to everybody. And I'm proud to say, and I don't know even if Christy knows this, but I just became a CPPM, which is Certified Professional Practice Manager. Would I do it again? No, but I'm glad I got through it the first time taking the test, and that's through the American Academy of Professional Coders. 5.5-hour test. All they said is bring a calculator, and so you know what it's all about, metrics and everything else. Folks, and if you haven't taken a class with me, I've been in practice. I now help to consult and manage several practices here. So I will tell you that this information here today, and I don't know if you're watching it live or it will be archived for you to watch it again too. This is fluid. It's not that it's not going to happen. It is starting January 1st, 2021. It's how is it going to be adapted by every payer? How are your PI, your work comp, whatever? The only way, obviously I inform ChiroHealthUSA. I teach for NCMIC, I teach for foot levelers. So, if you see me at least virtually coming to your town, then, attend a class. But one way you could be on, as things happen, I will post it. And as Christy said, facebook.com/askmario. All you have to do is like me. It's not a junk thing. It's not a sales gig. It's just, Christy and I said how we answer like 500 emails a day, and, it gets crazy sometimes. So do that, have your staff do it, but make sure you like me, put me in your notifications, and then get to it, okay? All right. I've got a lot of information to go through. Hopefully you have a pad of paper with a pen or pencil next to you so you can write notes down. I'm hoping to get some questions in, but if my email is doc@askmario.com. I did provide some notes as well, so if you have questions, you can always ask, okay? What we're talking about here, folks, is the standard of care. I personally, and this is going to come out wrong, but I don't care if you are in an insurance practice, all PI, or I'm just going to do cash. Okay. And, let's face it, cash is more, becoming more and more prevalent, although you can't be cash with Medicare. Okay. But nonetheless, if you talk to malpractice carriers such as NCMIC, they will tell you that the most common classification of a patient that sues a chiropractor is the cash patient. So your documentation, just going cash doesn't mean you can't or don't want to do documentation. And really, you're held up to the standard of care, which the standard of care is defined as the type and level of care an ordinary, prudent healthcare professional with the same training and experience would provide under similar circumstances in your community. And so with a case, and I don't do peer review. I teach peer reviewers. I do testify in court periodically, but it's always for the chiropractor, never against the chiropractor. But the key is that informed consent, examination, documentation, these are just, it's like our bread and butter. I mean, if you don't do it, sooner or later it's going to catch up to you. And I know you're listening and you go, I know I should do that, but I have to see patients too. I understand, up until just a couple months ago, I was in practice seeing 60 plus people a day. I have a scribe in the room. That's the way to go. That's not what this class is about, but it's about your examination, okay? When you look at the standard of care, it applies across the board to every classification of a patient because, there are HIPAA audits and board of examiners, the Department of Professional Licensing, and of course the patient can sue too, okay? So we're going to talk about the examination here, which I hope you do an examination, but when you do an examination, you want to document the materials that are supposed to be documented, because if it's not documented, it never happened. Okay, so our primary mode of examination is through what we call the E&M code. Okay, evaluation and management. Evaluation is the examination. Management is the medical decision making, the case management, if you will. Okay, now, keep in mind that a new patient is classified as somebody who has not ever been in your office or not in the last 3 years. I don't care if they were cash before and now they're a PI. I've got all this, paperwork to do and, forms or whatever. It doesn't matter. It's when did you last professionally see that patient? If it's been 3 years or longer, that's considered to be a new patient, and that would be the 99201 to 205, and established patient 99211 to 215. That's changing slightly, and we'll get into that. Back in 1995, which for some of you younger practitioners, I was in practice before 95, but I don't remember the evaluation and management process before that. It's kind of like, we've been using the 1995 and 1997 guidelines. 1995, when the guidelines came out, think of it more like functional medicine. It was how the doctor in general looks at all the systems. But then you had, the highfalutin cardiologist, and it's like, I never touched the anus, whatever, right? But it's how does the heart affect all these things? In our profession, is how does the nervous system affect all these systems? And that's the 1997 guidelines. So they came out with 95 guidelines, and the specialist said, not me. And then they came out with 97 guidelines, and they kept saying, okay, we're going to combine these together, and someday we'll just have one set. And they did try it in 2004. It failed. It was in like the beta testing sites. Then they tried it in 2010. It failed. Now they've done it in 2020, and guess what? it's a done deal, folks. It's not, I would say we have until January 1st, but it's even been published in the Federal Register, so it's not going away. Okay, so count on it just like you're going to count on the sun rising tomorrow. Okay, so when we look at the key elements currently under 1995 and 97 guidelines, understand that we have the history, the exam, and the medical decision making. That's what really drives the code. Obviously, without getting too heavy duty into it, the more complex your history is, your exam, or especially the medical decision making, the higher the code is, the higher level. Okay, like when we say a level 3, 99203, a level 4, 99204. By the way, most doctors, I learned in my certification courses, most doctors undercode their exam. Now, I'm not telling you to upcode it. It's just you want to make sure that your documentation, you document what's medically necessary and then code by what you documented as well. Okay. So when we look at the history, that would include the chief complaint. You always want to have a chief complaint. And then we have the HPI, the history of present illness, review of systems, and then what we call the PFSH, which is past family social history. So for a new patient or somebody with a new episode of care, a new injury or an exacerbation, you're going to, reiterate all of that is applicable. The HPI, which is nowadays we teach LM and OPQRST for location, modifying factors. N is for numbness. Then the onset, provoking, palliative, quality of pain, which is it sharp, is it dull, radiation severity, and timing. Okay. So 1995 guidelines are more of a general multi-system guidelines. So if you do functional medicine and you're looking, and I think of, going to the medical doctor's office, they look up your nose, they look in your mouth, they look in your ears, they listen to your heart, they listen to your lungs, they check your abdominal, area and, pulses and everything else. 1997 guidelines are more specific in that it's how, as it says here, how one system, for our case, the nervous system, affects the eyes, the ears, the swallowing, the heart, and so forth. That there's neurogenic asthma, it's just like I've had people come in who had problems, difficulty in talking or sleeping. And then we adjust them and their function improves. That's what the 97 guidelines, that's the way I practice, is using the 97 guidelines. Well, currently, you're supposed to have in your compliance manual. Oh, wait, do you have a compliance manual? That's required by law. Okay. I don't care if you're cash or whatever, it's like risk management, asset protection, and I want to protect your asset. Okay. Because you have to have a compliance manual, which is a corporate compliance manual. And then you have your HIPAA manual. Okay. You can have an employee manual too. Okay. It's kind of like, having a license. You just got to do it to have business. If you don't have manuals, go to askmario.com. We're in our 11th edition and everything is done for you. The forms, everything, you can go through it. Okay. That's not what this class is about, but whatever you use, if it's the 95 or 97 guidelines, you're already supposed to already have that in your compliance manual, because a peer reviewer can use whatever guidelines they want. And they're going to use the guidelines that are more advantageous to them, not to you. If you say, I use 1997 guidelines, then when they do peer review, they have to review you using the 97 guidelines. Okay. So put that in your manual. Well, the same thing with what I'm about to teach you here. Keep in mind, this is a 36,000 foot overview of the E&M guidelines. When I did my certification courses, I took a class on the new 2021 guidelines. It was 6 hours long. I know you'll be sticking, pens in your eyes and hitting yourself with a hammer over the head after 6 hours, okay? Truthfully, 2 hours should do it, okay? But this is a 1 hour class, so don't feel like you've heard everything here. I'm giving you the basics right now. The basics, which you'll know what's going on when I'm done, okay? All right. So 1995 guidelines, you had these different codes here, problem, focus, expanded, and the coding was 99202 to 205. Now, the reason why I don't have 99201 there is because it's not made for doctors. That's called the nurse's code. That is for nurses to do, not for a doctor. So you should never be doing a 99201. That's just out of your wheelhouse, okay? You're better than that, okay? All right. So, here, that's where we looked at, a brief or an extended and how many elements of the history that you went over, the LMN, OPQRST, okay? All right. Let's face it here. If you do functional medicine, you're going to look at single organ systems. So you're going to see, how is the heart functioning? How are the lungs functioning? How are the eyes doing? The ear, ENMT, those kind of things there, okay? If you look at your individual organ systems, your review of systems, which, by the way, is typically poorly documented by most chiropractors, it's like the vital signs. Do you take their blood pressure? You should. All right. Do I listen to their heart or look in their ears? No. But blood pressure? Heck yeah. Okay. And so, anything that has to do with the chief complaint, you're going to look at these and, you want to examine them and then also talk about it in your review of systems. But when you're going to examine them, you're going to examine for these type of things here, okay? Cardiovascular, palpating their radial pulse, their pedal pulse, whatever it might be. Gastrointestinal, you're going to be studying that. So I'm more orthopedically based, but I understand there are doctors out there, and you might be one of them, that are more functional medicine, using like vitamin and mineral supplementation, homeopathic, whatever it might be, okay? So these are the different kind of organs we look. Now, in 1997, you probably recognize this picture here that I have for 97 guidelines, because it's how the nervous system affects the different organs. It affects the joints, it affects the muscles, but also organs too. And so here we are restoring the nerve flow to these bodily structures, whether they be organs, joints, muscles, whatever it might be, okay? And so there, again, you're going to be looking at different bullets. That's what you should have been doing since 1997, okay? So for the last 20, plus years here, okay? So when you're doing a systems exam, how does the nervous system affect, their vital signs, their eyes, their ears? Do they have tinnitus? Do they have some visual problems, like from a migraine, headache, whatever it might be? Okay, the liver and the spleen, everything else there. This is the kind of stuff we look at. Okay, and so a patient that has sciatica often may have some other trophic changes, such as with the skin, the muscle weakness, of course, paresthesia, whatever it might be. And that's usually using the 1997 guidelines, okay? Looking at the skin, you want to look at the skin not only, for the turgor of the skin, but you're going to be looking to see, are there any rashes? Because keep in mind, shingles, and I see a lot of cases of shingles, things like that. So I just want you to understand the 95 and 97 guidelines, and what you use and the way you examine the patient is not going to change that much. It's how you document and how you determine the code that will change, okay? So don't lose me yet here, because I want you to stay with me. Now, just forget the slide, just listen to me for a second. If I were to list down every problem the patient has, There are some of those problems in what we call the problem list that I'm going to actually treat. There are other ones that will complicate the case, which means it causes the patient to heal slower than normal. And then there's comorbidity, which means that it may cause death, okay? An example might be if a patient has diabetes, I can treat them, but they're going to heal slower, so that's considered to be a complicating factor. But if the patient has severe demineralization, osteoporosis, or they have bone cancer and I adjust them, I may actually cause them more harm. In other words, risk versus benefit. There's too much risk to even treat them. Those are what we call comorbidity factors. So all that, when we think about it, I call them, it's kind of like as you're rubbing your chin, it's like the doctor actually does get paid to think. And the more complex the case is, the more time it takes. And so therefore, it's the higher medical decision making, and therefore you code higher. Like a patient that comes in that has been in an auto accident, that has post-concussion syndrome. I had one referred to me by a neurologist. I was the 11th doctor to see her. Okay. Now that is a level 4 exam for sure. Now level 5 is life and death. And unless you have like an ambulance bay in your office, they're probably not doing that. Okay. But I would tell you that most doctors, if they charge for an exam, and I don't know why you leave money on the table. Okay. And so, even our Medicare patients that don't, Medicare does not cover an exam, we put them under CHUSA, under ChiroHealthUSA. In our office, they get a discount. And literally, when I explain how their insurance, not I didn't buy it, when I explain how their insurance covers what we're doing, and that what they have to pay out of pocket, but if you have ChiroHealthUSA, you get a discount. And literally, patients say, "What's the thing about it?" Because the discount often is more expensive than the $49 for the whole family, by the way. Okay. So they literally say, "What's to think about?" Okay. And I was a little nervous at the beginning of going to ChiroHealthUSA. We went ChiroHealthUSA probably 6-7 years ago. We have hundreds, maybe thousands on ChiroHealthUSA because their insurance sucks. You and I know that. $10,000 deductible, 10 treatments for the year, and it's like, this person has a herniated disc. So keep in mind that, your medical decision making, it's like document that you went through their medical records, document any further tests that you might have ordered, like if you sent them out for x-rays or lab work or whatever. Okay. And then when you look over those reports, just make a listing, kind of like an itemized list of what you looked at, like the imaging report, like their x-ray report, and then what it meant to you. That's your medical decision making. Okay. That still is going to, I start off this way because I want you to understand, if by chance any of you out there are just not documenting properly, medical decision making is the most important of the 3 elements: history, exam, medical decision making. Medical necessity is the most important, okay, but how complex is this case? That's what you want to look at, okay? Now we get into the good stuff, okay? All right. So now when we look at the E&M guidelines for 2021, okay, there's time. I just did a class through the AMA. I just did that less than a week ago. And right now there's no other changes. You are up to date on all the information with this class here. I'm just, in our 2-hour class, I go into examples a little bit more. Okay. But, we have some time between now and January 1st. And, who knows what they're going to do. But this is the way I would say 98% sure of what it's going to do. Okay, so it's not like, it's still on the drawing board. It's a final, it's done. But how's Medicare going to go for this here? I will tell you, Medicare and AMA together worked on this, so Medicare is in. Now Geico and Flo with Progressive, we'll see what she does, but right now we don't know how everybody will change. And work comp is, sometimes they don't even wear shoes there. Okay, all right, okay, you know what I mean. So now just hang with me and just listen to this. The reason why they being the AMA and CMS wanted to change things here is it's kind of like the way we practiced in 1995 and the way we practice now are different, or at least they should be different in your office and mine. We have electronic health records. How do I do all the notes and still, see 60 to 70 people a day? And we do. All right. Well, we have a scribe. If you've been to a medical doctor, and believe me, I just did a consultation with a medical doctor this morning for their office because I'm a certified professional practice manager, and it's like they don't have it down either. But when they walk in the room, the MDDO, many times they'll have a scribe, and they'll walk in and go, "Hi, I'm Dr. Fucinari, and this is my scribe, Ashley." Okay. And, Ashley's putting everything in the computer because that way it leaves more time for me to spend with you, the patient. You see? Well, the scribe, that information that staff puts in now, actually in 2019, the AMA and CMS said, you know what, that counts toward, the doctor, you don't have to redo it if your staff has done it. And that's why, like in our office, using this medium, using Zoom, and not that we charged for the Zoom, but the consultations have been cut down from 45 minutes to 15 to 20 minutes, and that's with an exam because all the information is gathered first. You see, and coronavirus really spurred that on. So, we call the patient up and we actually set up an appointment with our medical assistant, and she calls, and then she's got, a form there, and basically she goes through chief complaint and then the HPI review of systems. So when the patient actually comes into the office, that's already done for the doctor. The doctor just reiterates or asks a few questions, partially to let the patient know we know what's going on in your case. So the new guidelines takes that into account, that your staff may be entering in elements of the HPI. You understand that? And that's why it says the aim of the framers is to reduce administrative burden, which means the doctor doesn't have to redo everything. And if everyone would just get on the same guidelines, whether 95 or 97, that's gone. That's being put into a museum. 2021, January 1st, we're all going to it. And if you're not taking classes, you are going to be sorely left behind. Okay? It reduces unnecessary documentation that's not needed for patient care, which means the staff already asked me that. Now the doctor came in and asked me again. Okay, and ensure that proper payment is forthcoming. So first of all, a 99201, when you look at the actual definition of a 99201, the doctor's presence is not required. You understand that? It's called the nurse's code. It's for taking a blood pressure. That has zero medical decision making. And the AMA and CMS said, this is, worthless. And that's why it's gone. So there's going to be doctors out there who put in a 99201 and file it with an insurance company. And then the insurance company is going to kick it out and say, this is a non-existent code. What are you talking about? I've always used this. Well, you used it wrong. And now they finally just deleted it. Okay. So that is going to be out of your software. And that brings up something else. Talk to your electronic health records software system. Are they going to be adapting for the E&M guidelines for 2021? Ask them. And they go, what do you mean? I took Mario's class and I know about these guidelines. Are you going to come up and you're going to upgrade our software for it? See, all of a sudden they'll be sweating the bullets, not you. Okay. All right. So, when you look at, like, most commonly a chiropractor does a 992, 03 or 213. Sometimes we might do a level 2 exam, sometimes a level 4. Well, the proposed E&M changes, and I would even take that proposed off and just say the E&M changes here for a 99213. It requires a medically appropriate history and exam and a low level of medical decision making. And so usually the time element. Now, in the past, we never really talked about time because time was not used or least used unless you're doing counseling. And if you're doing counseling, that's a whole different set of codes. Okay. So typically a 99213 established patient is going to take between 20-29 minutes. And I'll talk more about this time. Whereas the 99214 takes about 30 to 39 minutes. Now, you might be thinking, oh, to examine the patient? No, it's everything. Consultation, exam, reviewing records, the whole bit, you see? Now, most doctors do currently use medical decision making and most likely will continue using medical decision making. A level 3 exam, 2 active or chronic problems that you're treating, well, cervical and lumbar DDD, you already met it. That's not a big deal, okay? All right. So when you look at the changes here, the documentation of the history and physical exam is still have to be done. It's still medically appropriate, okay? I just was talking to a doctor last week, and he goes, I'm just going to do cash so I don't do documentation. I said, you know what? Go work at Home Depot. That's the only way you don't have to do documentation, because even a cash patient needs documentation. Then the second bullet, the amount of history or number of elements, remember those bullets, are not going to be a factor. We don't care anymore. You do what's medically appropriate, document fully, but now we're not going to be counting up every little bullet to determine a code. And many of you, let's face it, never did that anyway. The basis for code selection, the third bullet there, is most important, will be the level of medical decision making or the total time spent performing the service, and if you wish, underline on the day of the encounter. So it's not what you looked at yesterday or tomorrow, it's what did you do today, how much time did you spend on the patient. It does not include clerical staff. It's just clinical time. Okay, so write that down. It's not clerical time, like time, up at the front desk, getting their insurance and all that. It's clinical time. Okay, all right. So the office or other outpatient services must still include a medically appropriate history or physical exam. The extent of the history and physical exam is not a determining factor. Okay, the nature of the extent of the examination is based on the treating physician. Now, when it says or other healthcare professional, many chiropractic offices are now getting nurse practitioners. Obviously, the MD DOs, more dollars for MDs. They have nurse practitioners, PAs to help to, I call it like the Amway downline here, so that they're making more money for the doctor up at the top of the pyramid. Okay, all right. So it's the clinical decision is what's really important on that doctor. It's like, mental power you're being paid for now. Okay, so keep in mind, right now until January 1st or December 31st, you're using history exam medical decision making. Okay, but as of January 1, 2021, the staff now can collect information. I would love to do, and maybe that's a thing for Christy and I to talk about, how the staff can actually help to make the time more effective for the doctor. Let's just talk real time here, okay? Doctors, we all understand. I mean, when I first opened my practice, 1987, okay, I got paid $21 for Medicare. Now, for a 98940, Medicare is at $28.95. Okay, not much difference, right? See, but people are getting paid $16 an hour, and rent goes up, power, everything else goes up here. So you have to become more efficient. So I always say to my clients, I go, okay, doctor, what are you there for? Well, you're there to examine the patient and do manipulations. The rest your staff can help you with, you see? And so the staff can collect information, and the patient or authorized representative may supply information. Authorized representative is their family in case of dementia, whatever, okay? Or a parent in the case of a minor, all right? And then this is reviewed by the physician. So your staff, if you wish, okay, you can still do it yourself, but the staff does the consultation as an example, okay? And then the doctor writes down, the doctor reviews it, and the doctor just puts a macro in there. I have reviewed the documentation. Historian, which is your staff, historian, and then you have the name of the person and the date. I have reviewed the information, okay? So how much history, how much examination it no longer drives the code. It's the medical decision making. But what if a patient comes in and it's a fairly simple, it's like a child, and let's say it's an 8-year-old with back pain, no trauma. Fairly non-complex case here, except the patient went to Dr. Google, okay, and comes in with this ream of things they printed off that they want to go through with you. And it's like, hopefully that's not too many patients, but they come in and they go, well, what about this? What about this? And you go through and you tell them, everything about, like, cancers and stuff like that, okay? So in those cases there, the medical decision making may not be representative of how much time and how complex the case was, because you had this patient, their parents, who went to Dr. Google and Medscape or whatever and printed all this stuff up. So there you may wish to use time, okay? I'm going to work really slow so I get paid more. That's not medically necessary, you see? Part of this is ethics too, okay? All right. So the definition of the time element associated with codes 99202, because we did away with 99201. That's gone as of January 1st. You shouldn't be using it now. Don't use it then either, okay? Will be changed from typical face-to-face time to total time. In other words, face-to-face time used to be the doctor with the patient. Now they understand it may be your staff. Let me just give you an example, okay? The staff, on the day of the appointment, they either virtually on the phone, it doesn't matter because you're not charging for telemedicine, you're charging for an exam. But they get the information from the patient. Maybe they're going to then bring the patient and take their blood pressure, take their vitals, whatever. But, all that there, the time is clicking if you're going to count time. But medical decision making is typical in our practice, especially when you have a patient that comes in that has baggage, I call it, which is like DDD, spinal stenosis, scoliosis, things that are not going away, that they've had a long time, and it's not your typical uncomplicated case. I don't know about you, but as I get older, my patients get older, and the cases have more and more complicating factors. Okay, second bullet, the amount of time associated with each code is going to be documented as well. If you're using time as the main documentation factor, medical necessity for the level of service must remain identifiable within the documentation. So even if you're using time, you're still going to list complicating factors to be considered. I always put that in there. When they see one of my doctors putting that in their note, they go, oh, shoot, they took Mario's class, because they're looking for those complicating factors. It could be PTSD, anxiety, bipolar, depression, obesity, morbid obesity. Okay. All right. So any of those things, diabetes, whatever is slowing down the recovery of that patient. Okay. Now, the last bullet, any payer contracts, may require another way to calculate the E&M code levels. So confirm how the payers are doing it, which means like work comp. It's just like now, work comp is state controlled. So see what they might just say medical decision making only. Okay. But the way the guidelines are set up in general is medical decision making or time. You pick what is most appropriate for the case. Because if you have a patient that is a complex comorbidity factors, but yet it didn't take an extreme amount of time, that doesn't mean that all the brain power is not going to be documented and taken into account. Okay. All right. So that non-face-to-face time, if you want to take your practice to the next level, then consider having at least a scribe. Okay. And kids nowadays, I sound old here, they were raised texting and on the thing. And so as long as they can type and they can put together a sentence, they can be a scribe. Okay. So, over 18 preferably. Okay. All right. Now, when you're looking at time, minutes spent on the following activities on the day of the encounter can be billed. Okay. And that would be, as an example, reviewing tests in preparation for the patient visit. When you get 2 inches of medical records and you're reviewing through the MRI and the x-rays, even looking at them, obtaining or reviewing a separately obtained history, which would be your medical assistant, your scribe, or your, in consultation, performing a medically necessary appropriate exam, which is what we do now, counseling and educating the patient or the family, ordering other tests, MRI, or sending them to a neurologist, whatever it might be. Okay. Medical decision-making coding is based on the number and complexity of the problems addressed, the amount or complexity of the data, and the risk of complications. Okay. So when you're looking at documentation of time starting January 1st, it's the typical time, it's the total, and I bolded it here, total time spent on the day of the encounter, not including clerical time at the front desk. It's all clinical time, either you and or your staff added in everybody together. Okay. So that's when you look at time. Okay. So it's the total time on the date of the encounter, as I said, including qualified healthcare professionals. Depending on what state you're in, you may have certified chiropractic assistants, or at least qualified, which be trained. Okay. Including the time spent by the doctor, and again, not front desk. Okay. Preparing to see the patient, such as a review of their x-rays, their MRI, whatever it might be, their lab work. Obtaining or reviewing a separately obtained history, medically appropriate exam, counseling, ordering medications, independently interpreting results, like looking at the lab and you're doing functional medicine and you're looking at the lab results and determining the treatment to do. Or it could be, looking at soft tissue changes at post traumatic in an auto accident. And I did a webinar in the past through Foot Levelers, the role of radiology. And you want to look for striations in between the muscles, which could be bleeding, things like that. okay? So all that goes into the time. One thing you can start doing now is looking at the time and kind of looking at, and if you're talking about, the Cubs, okay, get off of it, all right? If you're talking about the Arizona Cardinals, now that I'm in Arizona, they're winning, so, that would be worth it. No, okay? It's clinical time. To adjust the patient, it takes 5 minutes. To talk to them about the weather, it takes 40. You're not getting paid for that 40 minutes there, okay? So, obtaining or reviewing separately history, medically appropriate exam, how much time do you take now? And just look at that amount of time, okay? And so how are they going to document? Do you have to put in units of time or minutes or whatever? We don't know yet. How much itemization, like for each thing you did? Probably, but we don't know yet. All we know is going to be medical decision making and time. So you're going to decide, and it might be on a case-by-case basis even. So here it is, folks. This is it. If you're looking at that pre-service time and the post-service time, that's the total amount of time you did on that day. Here it is. And you can see like a 992, like a new patient, 202 to 205 is basically on 15-minute increments, you see. 99212, it's more like 10-minute increments. See, they took that familiarity with the patient, with an established patient, into account. So now you look at the total time. If I spent 45 minutes on a new patient, that's a 99204. As long as it's medically appropriate, don't put down lumbalgia as a diagnosis, okay? Don't do that. Smack, smack, all right? If you need help on diagnosing, again, I'm not trying to sell you something. I wrote these so it helps people. Go to askmario.com. I have a book, a coding book there, and it gives you all what are considered long-term codes, okay? If you're using lumbalgia, cervicalgia, you're going to get audited. You're going to end up paying back money, okay? Time to get the, adult taste buds. For medical decision-making, as I said, it's the process of establishing a diagnosis, assessing the status of a condition, and selecting a management option. Obviously, we're only going to do an exam on, a new episode, a new injury, and a re-exam. That's all we do as chiropractors. We don't do an exam every day, okay? So the types of medical decision-making are still going to be, straightforward, low, whatever it might be. We don't do a 99201. That's been deleted. A 99211 doesn't require the presence of the doctor, so you're not going to do that, okay? All right. So there are definitions like a test, independent interpretation, independent historian, and risk, okay? So when you're looking at the number of diagnoses here, these are, again, your problem list, okay? And then the complexity of the data to be reviewed, that's what you're going to be documenting for medical decision making. So, when you're looking at the number and complexity of the problems that are addressed during the encounter, the complexity of the data and whatever it might be, okay? So, a couple here, one back, yeah, right there. So, an independent historian would be like your medical assistant, your CA, whoever it might be, who are doing the work for you. And actually, that's worked out really good. It's kind of like once, the patient schedules an appointment, the next day they meet with, or that day, they meet with the medical assistant, okay? She gets all the information. They've got skin in the game. And I will tell you, our no-show rate for new patients, just gone. New patients are there now, okay? So, at least they're rescheduling if something comes up, okay? So nonetheless, consider that as well, okay? All right. Okay, let's go back to where I was, which is here, okay? The risk of complications and or mortality of patients, those are the problems. And so you want to document all the different problems that patient has, because that baggage, if you will, is what complicates the case. And that's why it comes down to documentation. And it takes so much time. I talked to one doctor, he said, I see 50 to 60 people a day, but I'm in the office till 11 p.m. doing, documentation. Come on, get a scribe. And I explained to him how the return on investment is so good. I have no, I'm not selling you scribe time or, come to me and I'll teach you. It's going to make your life easier. Okay. All right. So, any consideration of further testing, other treatment options, if you're going to change what you're doing, maybe, a massage therapist or, other referrals that you're going to do within your office or outside the office, those are all into the medical decision making, the MDM. Okay. If you're looking at an x-ray and you're actually reading the x-ray for biomechanical alterations, it goes into the time for an exam and the complexity. Okay. I prefer to use medical decision making, but because I'm efficient, I'm quick here, but time is not always the best thing to do. Okay. And so those tests that you did, any interpretation of tests, lab tests, MRI, whatever it might be, and then discussion on the management with another physician if you call up the neurosurgeon, whatever it might be. The risk assessment, I have patients come in with cancer. I have an oncologist referring patients in. So, that's a high level of medical complexity. And I'm talking with the oncologist to make sure the PET scan didn't show any bone cancer, things like that. All that now goes into the medical decision making. It's like you want to document how much time you spent with those doctors. Okay. So when you're looking at medical decision making, we still have a 99202 to 215 cut out the level 1 exam. All right. And make sure you're documenting, the level risk. I said, make a macro, complicating factors to be considered, colon. And then underneath that, you can put in anything from PTSD, depression, all the way to obesity, scoliosis, diabetes, whatever it might be. Okay. And so medical necessity is still prominent here, but now you get paid for the time, even when the patient's not in front of you, that you're reviewing the files, you see? And that's where it works out better for you. Okay. Independent interpretation would be, if you are looking at a radiology report, because I always look at it. Sometimes I've had it before where it said a mild scoliosis, and then it was 34-degree Cobb's angle. See, now I have a better understanding of how to treat that patient. And that's why you might even document, I reviewed the x-rays, and then, comment after that, something to document that you did it. Okay. All right. So we're running short on time here. I'll take questions if you have some here, but this will be archived. And for my explanation, I do have the notes available. Christy will talk to you about how to get that here, but communicate the complexity of the condition and document your assessment, indicate what you're ordering, what you looked at here, and, do a clinically, medically necessary exam and document properly here. You might want to look at where are you kind of falling short right now. And, maybe you do want to use a scribe in your office. Maybe you do want to, if you're not using ChiroHealthUSA, I will tell you, all right, okay? I mean, I've seen Dr. Foxworth and I've seen his staff. They don't have wings, but they're all angels. They've helped my practice a lot, okay? And they've helped patients too. So if you're not utilizing them properly or fully, talk to them, all right? And look at the coding you do now. Are you doing a level 1 code? You weren't even in the room. Who cares? Okay, you got to do more than that. All right. And talk to your software, your documentation software. Say, hey, what are you doing about these 2021 guidelines here? Okay. And, by all means, go to facebook.com/askmario. If you need any manuals or whatever, askmara.com. That's the place to go there. And Christy, I'm going to throw it back to you here. And I hope, it's like taking a drink from a fire hydrant, but hopefully it helps some people there.
Oh, I think it was fantastic. You had a lot to cover in 1 hour, and you did an amazing job. So we have one question.
Caffeine free too. So,
does the time spent have to be documented in the note?
Does the time have to be documented? Yes. Yes. Now, total time for sure, but whether or not they will want an itemization like they are going to in physical therapy, they want more and more itemization, that will become more apparent in the next 3 months.
Okay. Let's see. I'm a mostly cash practice, but in network with Medicare. Do we have to charge more for a 99202 versus a 99203 when we have one flat fee normally for an exam?
I'm hesitating because the answer is yes, you charge more because you're charging for what you do. And a level 3 exam, a level 2 exam is, in my book, not that every kid gets this, it's kind of like a child. A level 3 is like my typical. A level 4 might be a patient with a lot of complicating factors or a PI, where I'm really looking at, post-concussion syndrome, things like that. All right. How many level 4 exams did I do in a year? Maybe 3, 4. Most of them are level 3 and some level 2s. Okay. So, a one set fee that was great in the 1960s and 1970s. Marcus Welby did that, but we, at least move up to Trapper John. Okay.
Okay. So there's a lot of information in this next question. So, okay. We had a PI patient who came in this week due to a new injury. He was in a new motor vehicle accident last week. Do we charge the E&M code, the first date of service, for this new injury using 99203 or 99213? He was in our office in 2019 as a PI patient, but settled.
It doesn't matter. It's an established patient. 99213, or if you did a lot of work, 99214, if there's post-concussion syndrome stuff. It's an established patient. I understand you got to do all that paperwork. It's an established patient, 99213 or 214, whatever.
Okay. Can we choose time or medical decision making on a per patient basis, or do we have to choose one and utilize it for all patients?
Per patient, because every patient is different. As I said, when the parent comes in with all those things from Dr. Google, okay, or Dr. Bing, okay, and go, what about this? What about this here? Then you can charge for time.
Okay. When getting an MRI findings from an outside facility, would you add the code and a note in the patient ledger on the date you reviewed the MRI and document you have reviewed the MRI? Would that code be a 99212?
Well, you don't, okay, that preferably, if it's done on the day of the encounter, the day of the exam of the patient, then you're going to charge for the time you spent reviewing that. Okay. Keep in mind, reviewing and reading are two different things. And, I used to be an X-ray tech. I taught radiology, X-ray positioning and physics at Palmer, but I don't feel 100% certain that I can read an MRI better than a radiologist. So I might review it, and that I charge for the time if it's on the day of the exam. Okay. If it's a week later, that's just going to be, you don't charge extra for that. Don't forget, a low-level exam is built into the manipulation charge already.
Okay. So several people have asked me about how to access the recording. It is automatically sent to you in a link to access after the webinar. So that will come to you in about 45 minutes to an hour. We are already 2 minutes over our allotted time. Dr. Mario, do you have a minute for one or two more questions? Or
I've got all the time you need, but you know what? If we don't get to your question, just send me an email. But in the header, just put down ChiroHealthUSA webinar and, doc@askmario.com. I'll answer the email for you. Okay?
he's really
That
good.
makes life easy. Okay.
In fact, if I type an M, it automatically pops up doc@askmario.com.
Yeah, there you go. So yeah, just send me an email if we didn't get to it, and then that way, I can answer your question more, fully and not rush through it. Okay.
I like that. So I put the email address in there at doc@askmario.com. Just make sure you put in the subject. I'm going to choose.
So in the subject line, just put ChiroHealthUSA webinar. That's good enough.
And Dr. Mario will answer your question because I just want to be respectful of everybody's time. And also, Dr. Mario has been working for the last 7 hours straight on the telephone and on webcam.
Yeah. It's been a busy day. Hey, and also, if you go to askmario.com and it says course schedule, I have a lot of virtual classes. I'm teaching in St. Louis, I'm teaching in Las Vegas and Michigan, all from home. Okay. So this will be presented in more thoroughly. It's not just a 1 hour thing. So take those classes, and now the nice thing is most of them are virtual. So you never have to leave home and you could take a class with me. Okay. All right, Christy, anything else?
That is it. I want to thank everybody for joining us in today's webinar. We have another webinar next week. We are going to do it's not a documentation workshop on documentation with Dr. E. So I'm super excited about that. And then we're going to start off the first week in October with hidden risks in your office. What are they and how to manage them with Dr. Amy Wood. And then minimize Medicare risk for peace of mind with Kathy Mills Shane. So we've got an excellent lineup for you. And again, just a reminder, we've got I think we're adding one or two more webinars for the rest of the year. And then that's a wrap for 2021. Or no, 2020, not 2021. I'm sorry, I'm getting a little ahead of myself. Before we start posting 2021 webinars. And just know that you will see Dr. Mario Fucinari back again in the future because he is a frequent guest because I love him so much. And he is knowledgeable. Did I mention he's funny? I love him. So Dr. Mario, thank you for always making time for us. And thank you, everyone, for joining us this week. And we'll see you same time, same place.
Thanks, everybody. Bye-bye.
Bye, y'all.
Bye.